Since the NIH conference on deep vein thrombosis and pulmonary embolism released its findings, the medical profession has placed a totally new focus on preventing thromboembolic disease. Identifying those patients at risk and aggressive application of prophylactic measures have become the new standards of quality care. And in no area is the need for those standards more necessary than orthopedic surgery. The NIH panel reported a frequency of DVT in total hip procedures as high as 70%, clinically significant PE as high as 20%, and fatal PE from 1 to 3% in patients who have no prophylactic measures. In fact, Hull and colleagues have reported that pulmonary embolism is the most common cause of death associated with total hip procedures. While it is true that not all DVTs end in pulmonary embolism, there are many other serious and far-reaching consequences associated with thromboembolic disease. The formation of blood clots can cause permanent and irreversible damage to the venous valves. Venous insufficiency may result from this valve injury and is often characterized by chronic pain, swelling, and skin ulceration. It is estimated that 5% of the U.S. population suffers from postphlebitic syndrome. Since DVT is a silent disease, many times presenting no clinical symptoms, the NIH panel concluded prevention is the only practical approach to these serious medical problems. Dr. Stephen Wolfson is a clinical associate professor of orthopedic surgery, Department of Surgery, Stanford University Medical School, Stanford, California. He has lectured and published extensively on the subject of venous disease and orthopedic surgery.
Certainly, we as orthopedic surgeons have a responsibility to lead the way in DVT prophylaxis. The incidence of DVT is well documented after total joint replacement, and with the work that's been done over the last several decades, we can identify, even quantify, risk factors for DVT in each patient. We also have several options for effective prophylaxis available to us. Patients who are at high risk for DVT and need protection should be getting it.
Understanding who needs prophylaxis begins with understanding the disease. Deep vein thrombosis is precipitated by 3 causal factors first identified by Virchow in the 1840s. They are stagnated venous blood flow or stasis, damage to the endothelial lining of the vein walls, and changes in the normal blood coagulation mechanisms. The presence of any one of these factors will not cause DVT. But, for example, consider the normal trauma associated with total hip surgery. The length of surgery and post-op immobilization at bed rest causes a prolonged period of venous stasis, especially in the operative leg. As with any major surgery, there are changes which occur in the coagulation cascade, which lead to a state of hypercoagulability. Stamakakis found that there was twisting of the femoral vein during dislocation of the hip, which may cause trauma to the femoral vein as well as complete venous stasis. And more generally, Camerata and colleagues recently described venodilation which occurs in veins away from the operative site and may result in vein wall injury. As a result, in patients who have total hip surgery, all 3 of Virchow's risk factors are involved, predisposing the patient to a very high incidence of clot formation. Dr. Stephen Haas is a clinical instructor in orthopedic surgery at Cornell University Medical College and assistant attending surgeon at the Hospital for Special Surgery in New York. He has also published significant research on venous thromboembolism and orthopedic surgery.
We do not yet understand all the implications of these 3 factors as they relate either to surgery or for orthopedic surgery in particular. For example, Camerata's study on operative venodilation identified a new area of generalized venous distension that we might previously have suspected would be confined to the operative site. Virchow's factors were postulated in the last century, yet they continue to be valid today. We are still discovering new ways in which they interact to cause thromboembolic events.
Numerous clinical risk factors for DVT also have been described in the literature, and a more complete listing is available in the published results of the NIH panel. However, the most significant risk factor is a previous history of DVT or PE. Next in importance is age. As age increases over 40, the risk of DVT increases dramatically. As previously mentioned, the length of surgery, especially over 2 hours, also increases risk. Obesity, previous stroke, and previous major surgery are also major factors. Caprini and colleagues in their studies on risk assessment recommended that patients exhibiting 2 to 4 risk factors be assigned to a moderate risk category, and those with more than 4 be categorized as high risk. They weighted previous history of DVT or PE as counting 3 factors, and age 61 to 70 and over 70 as 2 and 3 factors respectively.
If we consider the typical candidate for total hip surgery, it is not difficult to see why many have more than 4 risk factors and therefore fall into the high-risk category. The average patient is over 60 years of age, with many patients in their 70s and 80s. The average blood loss causes a significant increase in coagulation factors. Certainly, there is no question there is high risk for DVT, and these patients should receive the most aggressive form of prophylaxis.
It is important to consider where and when clots form when choosing which method and the appropriate timing of prophylactic protection for total hip patients. O'Meara and Kaufman surveyed the available literature on clot formation in total hip replacement. They and others have concluded that although most clots form in the calf, a significant number propagate proximally to the thigh, where they pose a serious threat. In Planet's study of total hip replacements, he concluded that of the patients who developed DVT, more than half had clots that originated in the femoral veins. He also pointed out that both the posterior and anterior approaches to the hip result in trauma to the femoral veins. Finally, the NIH panel reports that 75% of fatal PEs originate in the thigh. This thrombus, which was removed from a patient's lungs and then reconstructed by Nicolaides and his team, reveals a perfect cast of the iliofemoral venous system. Although the literature has reported that clot formation may occur any time up to several weeks into the recuperative period, Nicolaides observed that up to 45% of the thrombi form on the day of surgery. For this reason, an effective prophylactic regimen must protect the patient intraoperatively as well as postoperatively. Acknowledging that many patients are admitted on the day of surgery, prophylaxis should be initiated whenever possible preoperatively.
Any prophylactic regimen that we consider for total hip patients must provide protection against proximal clots, those which either propagate from the calf to the thigh or those which originate in the thigh. And it is also essential that the prophylactic regimen be applied for the entire period in which the patient is at risk. In the past, we might have assumed that prophylaxis could safely be initiated following the surgery. We now know that that would leave the patient unprotected during a period of significant risk during the procedure itself.
The available methods of prevention for deep vein thrombosis fall into 2 categories, pharmacologic and physical. Since no single method has been shown to be 100% effective in preventing DVT, nor is any single one appropriate for every patient condition, a combination of methods is probably most effective for moderate and high-risk patients. The efficacy of pharmacologic agents is believed to be due primarily to their effect on blood coagulation. Low-dose heparin, given subcutaneously, is one of the most widely used and well-documented of these modalities. But although it has been shown to be effective in reducing DVT in general surgery patients, studies have shown that it is less effective for total hip patients. The anticoagulant considered the current gold standard is warfarin, which is administered orally. Studies by Harris, Geyer, and others have documented its effectiveness in reducing DVT in total hip procedures. However, it does carry some risk of bleeding and must be monitored closely using serial coagulation tests. Another potential disadvantage of warfarin is that its anticoagulant effect can sometimes be delayed up to 72 hours. To achieve the desired prophylactic effect intraoperatively, therapy must begin well in advance of surgery. Aspirin has also been widely used as a prophylactic agent. However, studies by Harris and colleagues, as well as others, have left aspirin's efficacy unclear, and it is not among the modalities recommended for total hip patients by the NIH panel. Besides early ambulation, which in itself is not enough to prevent DVT, there are 2 widely used and proven physical modalities: graded compression stockings and intermittent pneumatic compression. Numerous studies have shown that TED thigh-length stockings provide a safe, simple way to reduce the incidence of DVT. Barnes and colleagues demonstrated their effectiveness for total hip patients. Until recently, it was believed that TED stockings achieved their prophylactic effect only by increasing venous flow velocity and thereby reducing stasis. However, a new study by Coleridge-Smith and colleagues has shown that thigh-length TED stockings virtually eliminated venous distension in the legs during the surgery studied. Venous distension is the phenomenon that Camerata previously reported as a cause of endothelial damage and one of Virchow's 3 factors. This finding supports the use of TED stockings in combination with other modalities for moderate and high-risk patients. The SCD compression system uses pneumatic compression applied sequentially. It differs from similar pneumatic devices in that it applies a decreasing pressure gradient to the full length of the leg. It begins and is greatest at the ankle, then decreases at the calf, and finally the thigh. Unlike single-chamber uniform devices which compress only a small area of the leg, the SCD system exerts the optimum balance of rate of compression and area being compressed to achieve maximum venous flow velocity in proximal veins. The below-knee device has less effect on the critical proximal veins. Studies by Mittelman and Nicolaides compared thigh-length sequential compression to knee-length uniform compression and found that thigh-length was significantly better at emptying the veins, particularly at the valve cusps, which is where clots are most likely to form. Hull and colleagues reported that sequential thigh-length compression used alone reduced the DVT rate in proximal veins by 50%. Hartman and colleagues were the first to report using a sterile SCD sleeve intraoperatively during total hip surgery. The potential to use this therapy intraoperatively on both the operative and non-operative legs is significant. Saltzman has reported that 80 to 90% of the DVTs in total hip procedures occur in the operative leg. Wilson and Watt also expressed concern for the twisting and other forces exerted on the operative leg and the resulting impact on the femoral vein. Using the sterile thigh-length sleeve in order to provide continuous sequential compression throughout the operation, they wanted to determine if pneumatic compression alone was enough to reduce DVT. They compared compression alone to IPC with aspirin and IPC with warfarin. They reported no significant difference in effectiveness as compared to the combined modalities. All 3 groups also received thigh-length TED stockings intra- and postoperatively. As a result, they concluded that the SCD device, used intraoperatively as well as postoperatively without anticoagulation, is effective, safe, and convenient. There is conclusive evidence in the literature that patients should receive prophylaxis intraoperatively, and Hartman, Wilson, and others have demonstrated that thigh-length sequential compression can be used effectively and conveniently without impeding the surgeon. The SCD sterile sleeve was specially designed for that objective. What follows is a step-by-step explanation of how it is applied in the operating room. Before the patient is draped, the non-sterile sleeve is placed on the patient's non-operative leg over a TED thigh-length stocking. The sleeve is then connected to the blue tubing set. The TED stocking is folded back along the patient's operative leg so that compression can still be applied to the calf, but also being careful to avoid a tourniquet effect at the popliteal. An impervious stockinette is placed on the operative leg, with a sterile wrap often used to hold it in place. Next, the sterile sleeve is applied to the operative leg. Notice that the sterile sleeve does not go as high up on the thigh as the non-sterile one. This is to prevent interference with the incision area. The sterile sleeve has 5 feet of extended tubing, which is unfurled along the patient's operative leg. The surgeon or scrub nurse takes the end of that tubing and measures in about 15 to 18 inches from the connector side. The tubing is looped at that location and secured to the drape at the edge of the table. This prevents the unsterile portion of the tubing from contaminating the sterile field while still allowing the necessary manipulation of the leg during surgery. The surgeon should flex, extend, and abduct the leg. After the sterile tubing is adequately secured and tested, the circulator connects the end of the sterile tubing to the blue non-sterile tubing assembly, which is already attached to the SCD machine. The SCD compression system may then be activated, and the sequential compression is applied without interruption for the duration of the surgery. At the end of the procedure, the sterile sleeve is discarded, and the second non-sterile sleeve is applied to the operative leg. Compression is normally continued for a period of 5 to 7 days following the operation.
It's been our experience after using the sterile sleeve regularly that it is a very practical way to apply pneumatic compression during surgery. It works effectively and does not interfere with the surgical procedure. Our staff has adopted it as part of our routine in total hip replacement.
The use of intermittent sequential compression provides effective prophylaxis without any risk of side effects associated with anticoagulants. Its effectiveness in reducing the formation of proximal clots is particularly encouraging. And for total hip patients, it is especially important that we take advantage of the sterile sleeves in order to use this therapy intraoperatively. However, there is still a need to have risk assessment guidelines and multiple modalities available in our prophylactic programs. As other studies have shown, a combination of modalities may be the most effective way to address Virchow's triad of causal factors.
For example, the SCD compression system is a proven way to augment venous flow and decrease stasis. The TED stockings eliminate venous distension and help reduce endothelial damage, and the anticoagulants address the hypercoagulable state.
What is most important is to have a plan. As the NIH and other concerned physicians have concluded, DVT and pulmonary embolism are serious medical problems that call for formal risk assessment programs and aggressive prophylaxis, and the need is especially intense for patients undergoing total hip replacement.
The best way to make sure these objectives become a part of our standards of care is to initiate standing orders that call for every patient to be evaluated on the basis of risk, and we must have a protocol in place that gives every physician an appropriate choice of prophylactic regimens.
The SCD compression system is an important component of those regimens. It offers a safe and effective means of reducing DVT in total hip patients, and one that is free of major side effects. It can be used preoperatively, intraoperatively, and postoperatively for the entire period that the patient is at risk. This program has been brought to you by Kendall Healthcare Products Company. For more information on TED and SCD compression products, contact your Kendall representative or call 1-800-962-9888.